Good afternoon, everyone who has joined us for our town hall. Our topic today is about the project that has been put together with the NMQF, which is the National Minority Quality Forum, the title of which is Uncovering Diversity and Addressing Disparity in Celiac Disease. We'll refer to the National Minority Quality Forum as NMQF throughout this afternoon's discussion, just to make it easier. NMQF is a national organization that's dedicated to ensuring that high-risk racial and ethnic populations receive optimal care. We're joined this afternoon by Mary Murray, who is the Vice President of Collaborative Action Networks for NMQF, and Salvo Alessi, who is the Chief Scientist and Strategy Officer for Beyond Celiac. A few ground rules that we have going into our discussion today, because we have a lot of important topics to cover on this pressing issue. And those are that we are going to monitor time and implement some time limits to make sure that we can get to as many questions as we can that were submitted by our audience. So in general, we know that celiac disease is underdiagnosed, misdiagnosed, or people with celiac disease relieve late diagnosis. And we have heard anecdotally from our community that people of color in particular struggle with these issues. In response to that concern, we launched a Voices of Celiac Disease campaign, really to collect the voices of celiac disease generally. But one of the things that has happened is that we've started to hear from members of diverse communities about the difficulties that they in particular struggle with when it comes to celiac disease. This issue has been a concern of Beyond Celiac's for a fairly long time, and Salvo in particular has had concerns along these lines and brought some new perspective to Beyond Celiac when he joined us about a year ago, a little more than a year ago, as the Chief Scientific Officer. So what happened was Beyond Celiac and NMQF formed a partnership to examine and address health inequities in the diagnosis and treatment of celiac disease. So Salvo, can you give us an audience-friendly description of the project?
Certainly, Amy, and thank you for the introduction. It's great to be here with you and Mary today for this important discussion. So I'll make this very simple for you. What this partnership with the NMQF try to do is leverage the power of big data. In this particular case, we are talking about claims data, medical claims data, Medicare and Medicaid, as well as some visualization tools that have been developed by NMQF, the organization, to pretty much map celiac disease across the United States, with the primary goal of identify health inequities, disparities across the country, between different states, the zip code level, and particularly with an even greater focus on vulnerable population, based on ethnic background, racial profile, but of course, as you can see, comparing this area that are, maybe even different economic income. Part of our partnership with NMQF is not just because they have the data and have the visualization tool, is because we can also share knowledge, our knowledge of celiac disease and the knowledge and understanding of these communities.
One of the things that this project includes is an advisory council that we put together to help us ask the right questions as we move forward with the project. Part of their task is to help us identify coexisting conditions that might be signs of misdiagnosis. For example, anemia with an unknown cause in adult men may be a sign of malabsorption, which could be a missed celiac disease diagnosis. And this slide gives you an idea of the breadth of expertise that we bring to the board that is currently looking at the project in its early stages. Mary, what can you tell us about the project and how it works?
Hey, Amy. Hi, Salvo. Thank you again for inviting me. I'm always excited to talk about this project because I do think it's really unique, and it's a great partnership and a really important way to start looking at celiac disease and kind of broadening the conversation and people's perceptions about it. So as Salvo mentioned, at NMQF, we do we invest in Medicare and Medicaid data. And just to give that a little bit of context for you, those are the two government health insurance programs. And Medicare is for people 65 and older. Some younger people may qualify for Medicare as well, but the main program is for people 65 and older. And then Medicaid is for people of all ages in all 50 states. And that's based on certain income criteria. And so together, these two programs cover about 140 million Americans, which is nearly, well, between 40 and 50% of all Americans. So we invest in this data at NMQF because we think it really gives us a lot of insights into what people of all ages and all socioeconomic backgrounds are experiencing when they enter the healthcare system. So with the Celiac Project, we're starting to take a look at the data to understand how celiac disease is captured and represented. Okay, here's the slide showing the different age ranges for Medicare and Medicaid. So you can see, again, we're trying to use this just as our best data set available to help us see how celiac is showing up across all these age ranges. And maybe I'll move on to the next slide. Okay, I'm sorry, I'm just going to double check where we are because I know there's another slide after this. So basically, we're able to not just sort of see the bar charts with the age ranges, but you'll see later as we move on in the presentation, we're able to kind of create a map, a visual map, and you'll see here. I think I might be jumping ahead too much, but anyway, this is what the map looks like, and maybe we should hand it back to Amy for her next questions, and then I can tell you a little bit more about the detail here in the map. But
right, so I think one of the first reactions that someone might have when they look at this map is, what does red mean and what does yellow mean? What are the dark spots and what are the light spots?
Okay, so so this is the Medicare data. So again, there's about 60 million beneficiaries in Medicare. And what we know is that when someone goes to the doctor, when a beneficiary goes to the doctor will see them, hear their complaints, maybe prescribe a test or so, and then attribute a code to that, a diagnostic code. And there is a diagnostic code for celiac disease. And so what this represents is that there are 72,000 beneficiaries out of the 60 million in the country that have at least one claim with a celiac disease code associated with it. And so those hot spots are the red areas where those beneficiaries live, those 72,000 beneficiaries with at least one celiac disease claim. And the yellow spots are, of course, where beneficiaries are living who don't have documented a celiac disease claim. It doesn't mean there aren't people with celiac disease who live in those yellow areas. In fact, that's what we're trying to uncover with this project is, are there beneficiaries, especially in those lighter colored or gray areas where people may have celiac disease but have not yet had been tested and been documented with a celiac disease claim, with a celiac disease.
So it would seem that the darker the red, the more people have shown up on the analysis that you've looked at so far as having these codes that are driving the data analysis.
Exactly right. That's where the beneficiaries live who have at least one claim with a celiac disease code in it.
And then the yellow is where, so if you kind of look at it on a scale of color, you're going dark red down to yellow in terms of where we're finding people so far as we look at the data.
Yeah.
Right. So I guess one thing to note about this is that this data is reflecting 1 year, and that brings up in celiac disease, that brings up one issue, which is that people in our community who have celiac disease often don't get follow-up care. So when you look at a 1 year slice, that tells you something about that fact about our community.
Right.
In addition to the total number of claims and where they are, what else are we able to gather from the map and the data that we've looked at so far?
Well, with this particular data, what we're able to do is dig deeper into some of the demographics, right? We're not seeing it here in the map, but we can, when we're actually using what we call an index, the celiac disease index, we're able to explore this data and see people by age, we can see by gender, and we can see by race. And that data all comes directly to us from the Centers for Medicare and Medicaid services. So, that's where people, like when you go to the doctor and you have to fill out that form and there's maybe a question on there asking you for your race. So it's self-reported and you might, you fill that out, and then that data all gets captured in your record and it shows up in the claims, and we can start to explore the claims from that point of view here. But one of the other things we can do is also look at some other disease areas or diagnoses, like Amy, you had mentioned anemia. We can start to look at, well, where are the anemia claims? And maybe we can start to, again, see, are there anemia claims among young men, and maybe even in those yellow geographies that might start to indicate to us that's where a likely undiagnosed population is, and how can we identify those folks more, not personally, but a little more specifically geographically, so that we can start to help them get care, get screened, get diagnosed for celiac.
So if we're thinking about what this is telling us about race, it seems like what we're looking at is that 90% of the 72,000 that we're seeing are white. And so I'm wondering, Salvo, if you want to weigh in on what that's suggesting to you.
Yes, I mean, again, so this, in a way, these numbers are not too much different from what you find in the literature without done like a lot of research. The assumption is 90% of the people shows up as white versus the 10% or less belong to different ethnicity. First of all, I would just say 10%, even if we start with that assumption, is a lot of people in the United States. Second, I would just say that I guess this make us start thinking more about the fact that 10%, can be related to the fact that you are not picked up if you live in the wrong state. And maybe if we look at this map again, and I don't know if you can visualize it for a moment. But we can go back, of course, in a second. People will realize that a lot of the heavy colors, the red and brownish and so on, are concentrated in pretty affluent area. Around large city in the kind of northeast, the south, or the west coast, Midwest. That per se, again, without over-interpreting this data, because to your point, Amy, this is just one snapshot or 1 year, speak, I think, to the disparity issue in the diagnosis of the disease, independent of where you fall, if you are black or white. Again, I was making that comment, if you're born in the wrong state, where there is not much awareness, or there is not a big hospital, or there are no doctor, particularly doctor that look like you, if you are lucky, you will be diagnosed late. If you are more unlucky, you will never be diagnosed. So that, to me, what this initial snapshot tells me.
And to your point, we have a map in the next slide where we've indicated where some of the major celiac disease centers are. And how we did that is we put stars on the map. That doesn't mean that these are the only celiac centers, but these are the major ones. And so we look at that, and then we look at where celiac disease isn't been reported, and then the census information about where people of color live in the United States. We want to look at all of those things. Salva, what does this suggest about the influence of economic status and access to a celiac center, which I think goes back a little bit to what you were talking about before? This is just more of a visualization of how those factors can come into play.
Well, it's interesting, Amy, you spot this out. I mean, because I have not seen this before, and it literally, I guess, seems to corroborate two of the things that I was saying before. You know, a lot of the high concentration of the diagnosis that we see is in area where there are center of excellence, which is not unexpected, right? I think the second thing is a lot of these diagnosis seems to be done in area like that, probably from a socioeconomic standpoint. You know, people have more resources no matter where you belong. Of course, I'm sure that when we start looking at dissecting this data, even in this area where we have the best diagnosis, right, or the most likelihood of being diagnosed, people of color would be less likely to be diagnosed. So to me, what this tells me, Em, is corroborating what I was saying. Again, let's still keep it as an hypothesis, right? I mean, as a scientist, I like to, you know, keep things framed in the right way. But certainly, you know, that shows what the best scenario could be, right? And even probably under the best scenario, your likelihood of being diagnosed if you belong to a minority, it's not that good. So imagine where you don't have those resources, if you belong to one of what I call here the yellow areas or yellowish areas.
Right. So on the next slide, we're going to take another look at the previous map with an overlay of 2010 census data based on race. And in the first view, we show people who identified as Black on the census. And in the second, we show people who identified as not solely white, which is a terminology that is used by the census. Salva, what does this map suggest to you?
That's interesting. It is almost the opposite of the other map, right? So I guess what that tells me is probably that the same area where we see less diagnosis, and again, 1 + 1 is not always 2, right? Even if we think it is, right? But I'm saying by association, the same yellow areas where we are seeing, particularly in the southeast, southwest, no, southeast in this case, a little bit in the southwest, but the same area where we didn't see a lot of color for, you know, red color for the diagnosis of celiac are the one that light up here more. And these are the area where we have a higher prevalence of African American population. So pretty much the same area where we have higher prevalence of African American population have less claims for the diagnosis of celiac. So again, by association, you would argue that part of the reason, you know, we may not have enough red in those areas is because a lot of the people that live there are people of color, and they don't get diagnosed because the assumption is they don't get the disease. Again, a little bit still of an hypothesis, but I think it would make sense with combining two very robust sources of data.
Why is it important to identify, and this really kind of gets to the heart of what this project is about, why is it important to identify everyone who has celiac disease, no matter what their ethnicity, race, or gender?
Is that for me, Amy?
Sure.
Yeah.
Yes.
All right.
Absolutely.
Well, I'll take it first. Mary has something
of course,
to say as
Mary
well.
can weigh in as well.
Right. So, well, putting even the ethics aspect aside, right? So I'm not going to go into an ethical discussion of, it's right that everyone that has the disease is diagnosed, no matter which color you belong with. We know that early diagnosis means also early intervention. We know that this disease, by its nature, it's already misdiagnosed or diagnosed late, which means the only intervention that you have these days, which is the gluten-free diet at the moment, you don't get the benefit from that diet earlier. You get it later, where your disease has already progressed and so on. So I would just say that no matter where you sit, you should have the same chances of being diagnosed with the disease. I think where the data that we are producing is very important is because I still like to think about as a scientist, as a data scientist, and the best way to convince people otherwise is showing the data, right? So I think that we're hearing a lot from people, even when go to the doctor, right? You get a doctor say, my doctor say I can't have the disease because I'm Black. Or my doctor say, it's probably not a big deal even if my antibodies are positive because it's probably a false positive. So I think to me, the importance of this data and the diagnosis to build that awareness that if you're Black or Hispanic, you can have the disease. That doesn't, maybe your chances may be low. I don't know that. And we still need to do more digging into that. The second thing is a very, another as important thing. So we know now that we have several drugs that are being developed for the treatment of celiac disease. So, the future, I keep saying the future look positive. If you have celiac disease, you have to feel good because within 10 years, we're going to have a treatment. Now, we don't want this treatment to be just for the white people or the people that can afford it. And we know that the way to test treatment is participation in clinical trial. And we wanted to make sure that people that participate in clinical trial are the same people that eventually is going to get access to this drug and take them for scientific reasons, first of all, because drugs should be tested in a population that reflects the breadth of the disease, but also, from a medical perspective and an access perspective. So
Right, and that makes total sense.
And clinical trials.
Right. Mary, how would you answer the same question?
Yeah, no, I think it's exactly right. I think we have to remember that, this is all part of a system, right? You go to the doctor and you have a complaint, and then the doctor tries to help figure out what might be causing that complaint, and then giving you the appropriate treatment. And all of that then gets documented, right, in codes, and it gets documented in your record. Then it's in that doctor's practice records. That all shows up in claims databases like this. And these type of databases are used when, as Salvo mentioned, a pharmaceutical company, for example, is preparing to develop a treatment for a particular disease. And they're looking at all the data and trying to figure out, well, okay, who's the most likely candidate who would, benefit from this treatment and who should be maybe participating in these clinical trials. And so you really need to have a good understanding of all of the populations of people that are living with this disease. And as you can see, we already can see just from the maps we've got, the claims data right now is underdiagnosing probably celiac disease overall, but most likely underdiagnosing it in certain populations as well. And so we can't say for sure that right now the claims data is giving an accurate picture of the disease. And so then there's not really good representation going to be in those clinical trials. And then once that clinical trials data comes out, all of that gets interpreted for clinical guidelines and treatment guidelines. And then back to the physicians having that one-on-one conversation with the patient and advising them, what is my risk, et cetera, for that. Doctors don't have that full body of information for that conversation. So it's a really, the data matters, all the way through the system. And I think for us in this project to be using the data to try to identify where are those underdiagnosed populations and to explore what else they might be getting diagnosed with. I'm keeping my eye a little bit on the chat, and someone has asked if the problems associated with celiac disease might be coded differently as GI issues. So that's exactly one of the things we're trying to explore. You go with a complaint, maybe you go with a GI complaint and the doctor codes it as GI. They don't code it as celiac, for whatever their information is. And so right away, you're sort of over-diagnosing the GI, but you're definitely under-diagnosing or completely missing the celiac diagnosis. And so we're tracking not just those codes related to celiac, but with our advisors, trying to identify those other conditions and then the codes related to those that might give us some insights into what conditions are people living with and being treated for without yet being diagnosed with celiac.
And although this is a new project for Beyond Celiac and in partnership with NMQF, and really kind of a first of its kind look at the composition of the total celiac disease population, but clearly this kind of work has been done in other conditions as well. And I would suspect that there are things that we can learn about what the end result of this kind of work can be. It's one thing to gather the data, but what do you then do with it? And then what happens as a result of it? So Mary, are there other examples of similar projects that would relate to the value of identifying diverse and underserved populations?
Yeah, not just diversity, but some diversity, but also this idea of overall, underdiagnosis. So we are starting to see across kind of healthcare, people really paying attention to this idea of underdiagnosis. And one example that comes to mind is multiple sclerosis, which also 20 years ago or more was thought of as primarily a disease of Caucasian, women, middle-aged women of Northern European descent, something like that. But don't put quotes around that. But that's roughly the perception, right? And that might sound a little bit familiar to people in the celiac community as well. And fairly recently, within the past 5 years, the MS Society, had been struggling with the fact that for 50 years, the overall prevalence of multiple sclerosis in the US, that number estimate hadn't really changed. In 1975, they estimated about 400,000 people were living with multiple sclerosis. And 50 years later, that estimate hadn't really changed. And so the National MS Society established a working group and started to think about how are we going to get a more realistic estimate of the people living with multiple sclerosis in the US. And they have a very detailed article that we could, I guess, make available to people later as a link about what their methodology was for that. But one of the things they did was say, okay, let's use claims data and see where are the actual MS claims, just like we're doing. But then they said, what is an algorithm or what's a formula we can use that will help us say, this is very likely an MS case. It just hasn't been diagnosed as that previously. And so they called that a highly accurate case finding algorithm that they could then apply to all sorts of databases. And when they did that, they actually raised that estimate of people living with MS from 400,000 to really closer to 1 million. And so that's significant. And then you can start to explore more deeply some of the racial and ethnic subpopulations within that million. But just having that approach of saying, here's our documented population, but we know there are people living with this condition that just don't know it and their doctors don't know it yet. And how can we start to quantify and find those folks and help steer them towards the right tests and treatment sooner?
So it's interesting to me that when we're talking about this, we're talking about maps and numbers and databases and analysis, but really as I'm listening to you describe the multiple sclerosis example, what it really comes down to is individual people who, as a result of projects like this, who were not getting diagnosed for whatever reason, maybe because, as some people in as some people of color have described to us, their doctor automatically decides that they can't have celiac disease, just right off the top, can't have celiac disease. So what it means is that these people get diagnosed, that the work that comes out of these projects relates to individual people and whether or not they get diagnosed. And so it seems to me that this project is going to answer some of the questions about where celiac disease is being diagnosed. But Salvo, how can we use the data to find out more about undiagnosed celiac disease and where it is? And Mary, you can possibly weigh in after Salvo on this question as well.
Yes, Amy, and the data about the diagnosed are as valuable as the one about the diagnosis, non-diagnosis or misdiagnosis. I think Mary was pointing out, I guess both you, Amy, and Mary were pointing out in a way to that. Misdiagnosis can be done for various reasons. There was a question, I think, about coding. The wrong code can be used. I mean, errors are much less likely these days with machine, and doctors are busy, but less likely. But aside from mistake in codes, and aside from your disease being classified as a different GI disease, and by the way, I guess this problem of perception that the disease is not present in certain people with certain age background is not just celiac, is other disease the same category like IBD, IBS. Actually, the problem is broader than celiac. But we also know, where I was going is that there are certain unique presentations of the disease. We know, from example, from our CEO, a primary manifestation where related to fertility. In men, anemia could be a sign, right? And there is a condition called dermatitis herpetiformis, which is basically what I call skilled celiac or gluten skin disorder. It's often referred like that, but that if you have that, you have celiac. So I think the way we are going is to mine the database beyond the specific code for celiac and start looking about some of these conditions which may point to someone having celiac, particularly in this area that are yellow, where we don't see the codes for celiac. So in other words, the fact that you are yellow and the code is not here doesn't mean there are no celiac people there. Could be for a number of reasons. One is they don't pick you for whatever reason. Your doctor doesn't pick you. The second one is you have been diagnosed with something else. Now, we can check for every possible condition. It would take us forever, but there are a few already that our advisor had suggested us to do. And why is that important, Amy? Because once you do that, then you can start do some target intervention in certain area, working with both the local community and the medical community to build more awareness about the importance of diagnosing this disease or diagnosing it correctly.
And Mary, what are your thoughts on this topic?
Yeah, I think I just want to echo what Salvo said, but really what you said, Amy, is that we're using data and these are numbers, but we are talking about real people. The consequences are significant for real people. And now I'm going to get emotional. I don't even know why, but one of the most heartbreaking comments I think I've seen from our advisors so far is with undiagnosed celiac among children. One of the diagnoses you might see is failure to thrive. Sorry. So that makes me emotional because that's heartbreaking, right? And how long are you going to live and sort of tolerate failure to thrive when you could identify it potentially as celiac and address it and improve that child's life? So, there are real people involved here. And I think that's what we can bring attention to. We won't answer every question with our project. I hope in addition to answering some questions, we will help to raise more questions and help other researchers ask questions that will bring us closer to more accurate and more timely diagnoses for people of all ages.
And that does sort of bring up the topic of when you're talking about a misdiagnosis or a lack of diagnosis, as you point out, Mary, that you can be talking about years where people do not feel well, do not understand why they don't feel well, get very frustrated because they feel like their doctor isn't listening to them and not solving their problem. And to my mind, sometimes I think misdiagnosis can be pretty dangerous. I mean, it's one thing when you don't know what's wrong with you, you keep looking. When you think you know what's wrong with you, but if it's not what's really wrong with you, you think you have an answer, and maybe your doctor thinks he has an answer as well. So I think that aspect of misdiagnosis and underdiagnosis is so central to this project. And so we are, pursuing ways to address it and then solve it, I guess would be the way to look at it. So I should point out too, that this project will also look at gluten sensitivity. That is perhaps in an even earlier stage in celiac disease in terms of us having set up the groundwork in the platform that NMQF has developed and used. But it's not that we haven't thought about it. It's just that we aren't quite as far along, I think, on that topic. And we will come back to it in the future. I don't know if either Salvo, you or Mary want to say anything about gluten sensitivity in relationship to the project.
Yeah, I will say a few words. I mean, first of all, again, very early stage of thinking, but surprisingly to some, there is a code for gluten sensitivity, non-celiac gluten sensitivity. Now, how much this code is used by doctor and how many doctors believe, even among the specialists, that this is a true disorder, that's a different question. So what I would say is that the challenge with non-celiac gluten sensitivity is even greater. I mean, one way to think about celiac and non-gluten sensitivity is like autism. There is a spectrum of disorder, right? It's where you kind of fall. So I think maybe the last thing that I would say is perhaps there are things we are going to learn from what we do in celiac first. They can help us also with that exercise, which is going to be even harder because there we almost have to start where we were with celiac 15 years ago to convince that this is a disease. Rather than it's not. So it can be a little bit more challenging exercise, but again, we are working on it.
Yeah, and I think again, sort of what we're hearing from our advisors, and then hoping to translate somehow into the index, into the project in general, is well, we know right now for celiac the treatment or the recommendation is the gluten-free diet, but we're also hearing that people go on the gluten-free diet without a definitive celiac diagnosis, and there may be many reasons for that. And if someone is already on a gluten-free diet, then it makes it that much harder to screen them to get the definitive celiac diagnosis. So I think we're trying to understand how we can use this project to come up with better guidance for patients, but also for physicians in terms of recommending the gluten-free diet. And then the other thing, again, that's sort of coming out, thinking about some of the social aspects that relate back to race and ethnicity, is the different dietary customs and cultures around gluten-free food. And so I think, again, and then how it relates to our, American culture. So if you've got children that are coming from, a culture or dietary background that is primarily gluten-free, but then they're taking part in school lunch program, which might not be as careful or attentive to gluten-free. So, their experience with celiac gets complicated. So, especially without being diagnosed. So, there's a lot to unpack. Again, I don't know that we can answer every question, but I hope that we can shine a light on areas where more research can be done that can help advance our thinking around treatment, around diet, and around how to do self-care, as well as how physicians can advise care.
One of the things that came up in the early discussions amongst our advisory board is that because of a view, perhaps in the general public and even among physicians, that celiac disease is not as common in people with color, it makes it even harder for them to follow the gluten-free diet within their family, because in any family there can be resistance to family members following the gluten-free diet, just have one bite, or, oh, this is such a traditional food. But in communities where celiac disease is not recognized by sometimes by the medical community, that resistance is even stronger because there's less familiarity with it and how it might apply to a given community. And speaking of community, I'm going to turn our attention now to some questions that we had submitted in advance. I don't know if there are questions coming out in the chat that we might answer as well, but these were ones that were submitted in advance by those who were planning to attend. And the first one is, it seems as if racial and economic differences will become illuminated. Do you think that this project will be able to shine a light on disparities across educational lines? And Mary, you want to take that? And Salva, then if you want to weigh in as well.
Yeah, I mean, I think to some degree we can. Our index is a lot of flexibility. So we invest immediately kind of in the Medicare and Medicaid data, but there's also other data out there around educational attainment or, food deserts, things like that we can, again, with the sort of recommendation of the advisors, pick and choose, but sort of put in these sort of data overlays that will help us see, again, where are people getting diagnosed and how does that relate to these other data sets, like you just saw, sort of like you did with the census data set, where are people of color living and where are people with celiac getting diagnosed, and you can see the relationship there. And so there are other data sets we can be looking at to see the relation to where celiac diagnoses are made, and in addition, where they could be being made.
And Salvo, do you have any thoughts on the issue of educational?
Not much to say. I guess maybe a different angle that I bring in education is, which education are we talking about? Education of the people, education of the physician, so both, right? So I think there are probably some association and correlation we can make even based on this data. And I mean, it goes without saying that some of the most affluent area have the best schools. That doesn't mean that those schools talk about celiac, but maybe two things, depending on which college you go, and I faced this recently, so it's a little bit higher education. But even in high school, there are some high school that I've seen in my own experience with my daughter, as we move across state, that they were more aware of celiac. They were even providing gluten-free cupcake of option, very rare, but there were a few. These are public schools. So I think by looking where by looking at zip code data when these schools are, you can make some association, perhaps, that if you're in a certain area where there are certain schools that are more aware, that somehow affect the overall community awareness, right, of the disease. Now it's a little bit of a long shot. I'm not sure that was the question, what the question was about, but that's probably the only other things I can add. Mary already illustrated very well.
So we have talked about how we're looking at two different sets of data, one from Medicare and one from Medicaid. And so with the Medicaid data, do you think we might be able to learn about celiac misdiagnosis in children of color? And Mary, I'll let you take that.
Yeah, again, we should be able to, just in a very similar way, see kind of geographically where Medicaid beneficiaries who do tend to be younger. I think I read a statistic about 40% of the people. So there's about 80 million people in Medicaid, all ages, up to 65. And then about 40% of them are under the age of 25, I believe. So definitely skews to that younger age group. So I do think that that being able to look at the Medicaid data and look at some of those diagnoses that our advisors tell us are common to the experience of children prior to diagnosis, again, we'll be able to shine a light on some of those things and maybe start to impact some of that physician education, but also inspire additional research into maybe some other claims data, private insurance data, where there may be more children covered.
Right.
So
Yeah, maybe another comment to that, and again, always providing a complementary angle to what Mary says. I think I go back to the issue that we are not just looking at the diagnosis of celiac, but also comorbidity. What you're gonna see in kids, in addition, unfortunately, to the issue that Mary highlighted, you know, and by the way, I get emotional about this too. So, which is the failure to thrive, you know, problem with growth, not reaching your even stature, and so on. One common association between type 1 diabetes and celiac disease, or Down syndrome and celiac disease, you know. So I think as we start looking at perhaps at the comorbidity of these two associations in both in area where this diagnosis is done very well, and in area where it's not done very well, perhaps if I think about an intervention is we can approach some of these areas in the zip code and say, what you guys are doing to be so successful, maybe other than having a center of excellence. So I think I was seeing a lot of questions here about, can we borrow knowledge from other disease to apply to this disease? And the answer is yes. I mean, Mary gave a perfect example of a disease that was completely misunderstood in terms of its demographic distribution and how this has changed. But I think we can even learn within the disease from places where there are best practice and you know, from the red to help the yellow become more red. And then I think that's another thing that as the project evolves, we should look into that. It doesn't matter if these are children or not, but particularly in children, when you can think about early screening programs that can be done even when they reach the school age. It's always, from an economic standpoint, more proposable to the payer that you approach, you know, two diseases at once than just only one. So yeah, these are some of the other, I guess, points I wanted to make as we were talking pediatric population.
Right. It's so when you think about this project and the way we're looking at claims data, you can see the important role that the healthcare providers play in what we're going to learn about celiac disease. And we had a number of people ask us about what can be done to help educate healthcare providers. And from our Voices of Celiac series, which I had mentioned at the start of our conversation, it seems not at all unusual that people with Black or brown skin are told they can't have celiac disease, or because of that, or because of their ethnicity. What kind of solutions to that problem might we see come out of this project?
Yeah. Well, I start on this, and Mary, of course, probably you can provide even a more applied approach based on maybe an NMQF advocacy experience, even more broadly with other diseases. So here, what I would say, first of all, I'm going to be very blunt. I think part of the problem why we don't have so much broader education in the physician community is because we don't have a drug right now for celiac disease. You know, and some people even don't think about this being a disease because there is not a drug. That's how people are educated to think, well, if, you know, there is not a drug, it's not a disease. But also, once drug become closer to market, private company invest a lot of resources in physician education, CME, and medical program, and so on, because that's the way that you, as appropriate, made the physician community aware of this. So I would think that that is a broader approach. It's something that we're going to see changes once drugs become available. A couple of other problems. I think we don't have enough physicians of color, particularly in the gastrointestinal area and particularly specialists in this disease. And we don't have enough young researchers of colors. So I guess to me, the issue is how we can use this data to advocate with the NIH, with the medical association, medical society to create award, to create incentive that would allow, you know, to increase the physician population of people. They don't have necessarily have themselves people of color, but being, you know, incentive to work in this community where we know there is a more diverse population. So the data and the usefulness of the data, it's to inform things that go from specific action that we can take, as I mentioned, but even policy changes that can be done more broadly, you know, by the NIH and other organizations.
Mm-hmm. One thing I'll just slip in here before I give Mary a chance to to answer the question is that the maps that we have, we were looking at the broad picture of the map, but there are ways in which we can look at specific zip codes to see numbers in specific zip codes. There are ways that we can look at the data in relationship to congressional districts. So there are a lot of ways that we can sort of segment the information that we're gathering to put it to the best use that it can serve. So sorry, Mary, I didn't mean to jump in there before you, but if you, we were talking again about healthcare providers and how we might be able to solve the problem that they're not recognizing the disease, particularly in people of color.
Right. So I think, so a couple of things. This is where your voices of celiac program and everyone's participation in that and sharing your stories and saying, this is what happened to me. I think even we've seen a few stories in the chat that way. You know, those need to be put together in a very compelling way that can be shared with physician communities, local physician communities, as well as through their professional associations. We do have 2 members in our advisory board that are part of a gastroenterology association. And I think through their participation, we can get recommendations on how to share what we're learning with you know, practicing physicians. Where do we start? Do we start with primary care? Do we start with the GI specialists? Do we start with other specialists? And does it matter? Do we have a different message for physicians treating children and for physicians treating adults? So there's a lot we can be exploring, and I think our advisory board can help us with some of that. I will say that within the index itself, in addition to seeing where the beneficiaries live that have celiac codes associated with their claims, and those who have other codes that could be hiding kind of a diagnosis of celiac, we can start to understand we don't have it in the index right now, but we can start to explore who are the physicians treating those patients with those conditions, and where are the communities, you know, where those conditions are maybe most prevalent. So then we could zero in there and start to have some local kind of awareness intervention. So there is definitely a lot we can do using the data from the index to help guide our interventions. And then there's a lot we can do using the stories that are shared with Beyond Celiac from patients and caregivers and parents. And then with our advisors who are part of these broader professional associations. I think with these sort of 3 sets of resources, we can really start to create a new kind of awareness campaign that can be compelling for treating providers.
Right. So it seems, I'm sure if you're an audience member and you're listening to this, it seems like we've talked about so many different things and so many aspects of the situation in regards to celiac disease, diagnosis, misdiagnosis, lack of diagnosis, the role that it plays in a broad variety of different kinds of communities. So I'll go first and sum up how I look at this program, which is I see it as the point where we start to ask the important questions, and that the project itself, after we find out what are the questions we need to be asking and what is the information we need to be gathering, then it points to us what we don't know and what we need to find out and how we can better understand what's happening in this broad celiac disease community. So that's the way I look at it. And Mary, I'll ask you overall, as our clock is a little bit ticking away, but we're doing well. What would be your concluding thoughts on the most important takeaways that our audience should have from this discussion?
So I agree with what you said, and I think I would add that it's a stone soup approach. If everybody remembers that story, you know, you don't have any ingredients to make soup, and so you just have some water and you throw in a stone, but then say you're making soup and then suddenly all the villagers come and somebody adds carrots and somebody adds onions, and pretty soon you've got a whole beautiful broth that everyone has contributed to. And I think this is the same way. I think we are starting with our index data and our collaboration sort of with patient advocacy point of view and a health equity point of view. And that's what we're starting with. But hopefully we're able to raise enough compelling issues that other people, other researchers, you guys who are patients start to see what's your role? How can you contribute to this soup that will help us really raise awareness about the patient experience with celiac disease and what new types of care and treatment are needed. So we are not expecting to do it alone. We're not even expecting to do it just the two of us. We are looking for a community, to create a community of multiple stakeholders all kind of moving in the same direction.
I like that analogy, and I'm jealous I didn't think of it myself. Salvo, what would your concluding thoughts or most important takeaways be?
Yeah, so again, I will want to re-emphasize this is a start, but it's a good start. And Mary is right. This is not just the two of us or the three of us. And in fact, there are already people working in addition to the advisory board with us more broadly. And we need to build more data. We need to add more information. We need to spend more time dissecting, more years on. So that goes without saying. But I would also, and that goes with the take-home message, I think that everyone that is listening to us, no matter where you belong, if you have celiac, if you don't have celiac, if your kids are celiac, I'll give you a little bit of a task. If you live in one of these zip codes in particular that shows yellow, see what you can do. Either talking to your neighbor, or if you see your neighbor maybe looks different from you and may have some of the problem, or you just are sitting at dinner and say, hey, by the way, you hear that there's some struggle, you may have the disease. Check your doctor or share your experience, right? And if you are lucky enough to live in one of the zip codes that looks, more brownish or paradoxically more brownish or reddish or whatever kind of that kind of heat map color is, then think about what you could do and share what you have learned that was very helpful for you, and you were the lucky one where your kids or your son or your daughter or yourself were made, were diagnosed sooner. So the most important thing is raise your voice, either doing through our share your story or being yourself an ambassador, depending on how much energy you are, but speak up no matter where you are. And don't take no as an answer from any doctor that will tell you that just because you are black or brown, you don't have the disease. Don't take that as an answer. I guess the good news is that now there is much more empowerment of any patient with a doctor. It's not just the doctor tells me what to do, is we have a dialogue. And don't just stop at the doctor level. Talk with patient coordinator, nurse coordinator, nurses. Sometimes they're even more aware of these things. So that to me is how you can already get value from this presentation, from what you have seen as a starting point.
Right. And I think Salvo's mention of voices and Mary's call for people to share their stories takes me back to the Voices of Celiac campaign that we're doing. I believe that the URL for reading and seeing these stories, and there's a broad variety of them there, is in the chat. And so you can read other stories, you can tell your story. And here's a screenshot that will enable you to see the URL. And then I'll just take our last minute or so to thank everyone who tuned in, who stayed with us. Mary, thank you for helping to describe what can be a little bit of a complicated project, we understand. Salvo as well for bringing your insights, and stay tuned because we expect this project to contribute a lot of information and discussion as we move forward with it.
Thank you.
And thank you, Amy.
Right.
Thank you for moderating the discussion, and thanks all for staying with us.
All right. So long, everyone.
Bye-bye. Thank you.